So hopefully 20, 30 minutes from now, we'll be done with that and we'll move on to the panel. So 5 years out from the ACA, what do we do now? We talked yesterday about what the ACA did. I don't want to spend a whole lot of time going through that again, but I do want to say just a little bit about how things have worked out. I'm going with the lower number of the likely effects on coverage, and based on insurance company statistics, it's very likely that in the private insurance market there are probably no more people now than there were before. There are more people in the individual market, fewer people in the employer market, and once again, the main effect of the ACA as regards coverage has been through Medicaid. If we see what's happened to the individual market, what we see is a larger increase in the first couple years and then a gradual lowering of numbers in the individual market in the last year or two. And the other thing to note is that the proportion of subsidized to unsubsidized people has shifted very much in a direction from more unsubsidized to fewer unsubsidized with the passage of time. Why has that happened? Those who are not eligible for subsidies have been increasingly discouraged from participating in the individual market because premiums have gone up so much. I mean, they've simply gone up a huge amount, 100% roughly from 2013 to 2017. And what we see is that if you look at a sort of gradual, moderate inflationary trend prior to 2013, after 2013, there was a big jump in the rate at which premiums increased, leading to a doubling for individual level policyholders and a more than doubling for family level policyholders. So, I mean, that's what's happened, and that's what's driving the trends in the individual market as to participation. Why were the increases so substantial? The main reason was adverse selection and the shift in the composition of the risk pool. And if you think about what we did in the first session, that should make sense to you. We cover a lot of people that are more expensive, people that are healthier are discouraged from participating because of the increase in prices, and the pool gets sicker, and what we see is what was very predictable given the way that insurance works. The ACA has also had broader effects. It's likely been responsible for some of the shrinkage in the employer market, although it's true that the employer market was shrinking before the ACA was passed. It's likely had some effects on employment. Small companies with employees fewer than 50 have been discouraged from growing because once they hit 50, then they're required by the ACA to participate. That's very expensive. They have incentives not to do that, so they're probably hiring fewer people than they otherwise would. This is somewhat speculative. You all know that the employment trends in the country as a whole have been very positive in the last few years because the economy's been growing again, so it's very hard to tease out what's what. But nevertheless, it might have been even better in the absence of the ACA requirements on employers. So the individual market, I mean, where do we stand? It increasingly resembles previous state high-risk pools, older and sicker patients, and mostly lower income who could benefit from subsidies because those who can't benefit from subsidies are increasingly being priced out of it. So what have we done? We've helped a lot of people who needed help. That's a really good thing. Big success of the ACA. We've also disrupted the lives of many who were happy with their insurance before and now can't get the insurance that they had before and may or may not be participating in the individual market as it presently stands. And we've done all that at the same time while perpetuating aspects of the current system, particularly its tendencies towards healthcare inflation that are threatening our national future. And is it hyperbole to say that our national future is threatened? I don't think it is. If we look at the prospects for the federal debt in the near future, what we see looks very scary. I mean, we're right now at levels of debt that we previously approached only during World War II, and the line only goes up from here. Now, why should that be so scary? I mean, we're a prosperous economy. We can borrow lots of money, and we've been able to do so up until now without any big disruption. Why can't that just continue? Well, the bottom graph here shows where we're heading. Right now we pay 7% of the federal budget in interest on the debt. But once it reaches a point where that 7% goes up to 15%, 20%, 30%, we're going to crowd out all other federal spending. And once that happens, the prospects for which are, maybe 2040 at the moment, that's roughly when you all will be in the peaks of your careers. We really could be facing a crisis. That's not good. That shows that we need to do something about healthcare spending. In particular, healthcare spending is 1 out of 2 federal dollars spent in 2018. It really is the problem with federal spending that is generating the debt problem that we're going to face, or I should say that primarily you guys are going to face, as opposed to people like me that are over the hill, that are not going to be in the vulnerable position that you all will be when this really hits hard. So my suggestion is going to be that the cost problem is at present the real problem that we face. And that if we could do something about the cost problem, the access problem would be much more amenable to solutions than it presently is. I mean, if we were not all crushed by the incredibly onerous premiums that we're paying for healthcare insurance, if we were not being crushed by the levels of taxation that are necessary to support that spending of 1 out of 2 federal dollars on healthcare, we would be in a much better position to take care of those who presently need help, who aren't getting the help that they need. So my suggestion would be that this is the pressing problem that we need to solve. And I think there are really sort of 2 approaches to do that that make some sense. We could move toward a complete top-down control, as many on the left are now proposing, have a single-payer system, have a Medicare-like system that would be compulsory both for you as physicians and for us as patients that we would all participate in, and set a budget at the federal level and thereby control costs and limit care that is being provided by bureaucratic decision. Basically have people stand in lines if need be, and you can only get what the system allows you to get, and that's simply how it is. That would work. It's definitely done a much better job of controlling costs in other places than we have done here. It's politically, it can be very difficult. This is now being discovered in Europe. I mean, they're having trouble keeping costs from rising, even in systems that are like that. Clearly, it would quickly, immediately, and universally lower your future earnings through imposition of the kind of cost control that mandatory Medicare would impose, except perhaps for those physicians who are lucky enough to be on important positions on the CMS committees that would set reimbursements for the things that they do at a more generous level than the things that perhaps you do. That is, healthcare finance would be even more political than it already is, not to mention the complete loss of any variety and choice that is now available in our poorly functioning system such as it is. So I think there's a better way. What would that better way be? I think it would be better if we had a system in which our willingness to pay as a nation for a given level of healthcare was reflected in prices that themselves reflected our individual willingness to put money down for healthcare that we actually found valuable to suppliers that were actually forced to compete to supply that healthcare. In other words, if we actually had a functioning market in healthcare, which we very much do not have, the cost problem would be mitigated by prices being realistic and by those prices being set by our willingness as a country to pay, rather than the open-ended kind of incentive to spend more and more and more and more that our present system imposes upon us without any demand-side restraint on willingness to pay. What would that look like? Well, on the demand side, ironically, the ACA is actually helping put more healthcare expenditure, particularly at the routine level, in the hands of patients and actual people having to pull their wallet out of their pocket. Of course, that's not enough. There would also need to be sensible regulation of insurance offerings, including a removal of the present one-size-fits-all straitjacket that the ACA has imposed on insurance companies as to what they can offer, so that people can actually buy levels of insurance that suit their financial condition and meet their needs as seen by them rather than by an insurance bureaucracy. But that's not the most important thing that would have to happen. I mean, you all having skin in the game with your healthcare dollars isn't going to do any more good than citizens of New York City having skin in the game when they're buying taxi service if they have one choice of what they're buying, and it happens to be the yellow cab company prior to the disruptive innovation of companies like Uber and Lyft that finally gave people a choice as to how to spend their transportation dollars in New York City. That is what we need in the healthcare system most of all. We need disruptive innovation on the supply side. We need new entrants to come into the market to supply healthcare that will attack and destroy the present healthcare industrial complex, which is set in its ways, which is lazy, which is undisciplined, which is harming people through the excessive care that it's provided, and that is exemplified by organizations like UAB and, I'll say a harsh thing, organizations like Blue Cross. These organizations are not going to change their ways. They are not going to do things any differently. Why not? Because they have no interest in doing things any differently. They're doing very well out of the present system. They have no incentives to do things better. What we need to do things better are new innovations, new supply-side innovations, and there are some signs of that happening. Burgeoning direct primary care. Primary care physicians saying no thank you to the insurance bureaucracy, to burdensome reporting requirements, to burdensome electronic health records that do nothing for medical care and that simply make medical practice torture. They're saying goodbye to that, and they're saying let's have a direct financial relationship and we can make medical care much better. There are moves at the federal level that are actually going to help us. For instance, the rule that was just issued by HHS forcing hospitals to post prices. Up until now, there's been no price transparency. This is a step in the right direction, even though it's not enough. But the most important thing are things, entrants like the Amazon, Berkshire Hathaway, and the JP Morgan foray into healthcare. They are going to, I hope, to do things completely differently and force our present healthcare organizations to sit up, take notice, and compete rather than be in the very comfortable position that they're presently in. We can do all that and we can still protect those who need help. We can bring those people into a functioning market by giving them the wherewithal to participate. That's not an impractical or impossible thing to do. It's a very practical thing that can be done, and that's the direction in which we need to move. There are legislative initiatives in Congress that will help to begin to move us in this direction, even though it's going to be a long and incremental process if we were to do this. But I think we have no choice either to move in a functioning market direction or in a more top-down control direction. We cannot stay with the present status quo, which is going to destroy you and your future financially, as well as continue to give us horrible value for money for the health care that we're presently getting. Now, Dr. Kertesz is going to present a divergent view from what I've just told you. And in turning the mic over to him, I simply want you to remember that yesterday he very suspiciously suggested that a Chinese premier directing our healthcare might be a good thing. And I don't say that that's definitive evidence that you shouldn't listen very carefully to what he says and that it may not have some validity, but could he be a devotee of Chairman Mao?
Okay, all right. I'm here. I understand where you're going with this, Tom. Low blow. It shall be returned. No, let's see. My slides were downloaded.
You downloaded them. PDF slides have the, yeah, the
2019 accidental. Okay. All right. Actually, there were a lot of ideas in what Tom said that I think are interesting, and I'm not necessarily in disagreement with. But some of the disaster mongering has remained despite our gradually getting more mild over the years. So I'm going to offer a modestly positive view of the future under the Affordable Care Act and where we're at. These are my premises. We should help people pay to help people with their health coverage. The Affordable Care Act expanded coverage. It certainly has not resolved fundamental factors that drive U.S. health spending upward, and on that you see agreement between me and Tom. We now face more or less the same problems with more people who were previously disadvantaged on board in our healthcare system rather than excluded from it. I would like to see us stabilize the ACA and the coverage that it provides. And we do have to address fundamental issues of pricing power and the promulgation of costly specialty services of all kinds. Tom emphasized one way of possibly doing that, which would be sort of direct to consumer purchasing, like Uber for medicine. I'm actually intrigued by that for primary care. I'm not sure that's really going to cover most of the cost pressures that we have in the healthcare system. Certainly, let's talk about the great benefits of getting rid of the pre-Affordable Care Act health insurance market, which arguably was more like regular insurance. The key factors of that prior market were to underwrite, which is to identify people's risk of healthcare problems by scrutinizing their records and asking them questions and denying them as potential customers if they looked like they were problematic risks, or charging them a lot higher price. So denial was common, and these are Government Accountability Office reports on how frequently even just total denial of any opportunity to buy insurance was built into the previous private market. Obviously, it didn't affect the people in the insurer market or Medicare or the Veterans Administration, but for that private market, refusing to serve people was a very important part of how it worked. This market was still very highly regulated. It wasn't really the free market, but it excluded a lot of people. Pregnancy and mental health and addiction coverage were great examples of the insurance market logic falling short ethically. I think it's really problematic to take the view that society's interest in the success of pregnancy and childbirth really resides with women to decide whether they want that to happen. I actually think we all have a shared interest in assuring that pregnancies are safe, and therefore I think we all kind of have to bear a certain shared costs in our insurance product, including if we are men, so that women have full and fair access to that coverage, rather than women or people immediately planning childbirth paying a sort of very high surcharge. It's not in my interest for my next door neighbor to have lousy prenatal care and have a kid who's dysfunctional and then needs tons of extra school assistance and then winds up not doing well in life. That's not my interest, even though I might be single and not married and don't have a kid or whatever. Mental health coverage is a really great example because very few of us factor into our calculations, I might have a mental health problem, or I might develop an addiction, or my child might develop an addiction. It's a very hard thing to calculate. You're a family of maybe well-to-do people who've never touched drugs and alcohol, and you're told, there'll be $1,000 extra a year rider if you want to cover your adolescent in case they should develop an addiction. How many people are going to say, that's right, that's the right product for us, honey. We need to count on the fact that there's a reasonable chance that Junior's going to develop cocaine addiction. It's just not how life works. So I think the market logic falls short in a number of realms. How did the ACA work? Basically, it has these three stools. I'm sure you've gotten used to this, but these are legs of the stool. Prohibit discrimination by insurers by saying they can't rule people out based on pre-existing conditions. Require everyone to buy the insurance product, which is the mandate that was gotten rid of, and provide subsidies to purchase based on income, so that if the price of the premiums goes up, people get more support to purchase. Those latter two things help prevent a death spiral, which is why we don't have one. Essentially, people who are better off help pay for the less well-off. We always do this. Prior to the ACA, I would say maybe in many ways we did it the wrong way. We sort of had health providers jack up the prices on private customers and declare bad debt and send collecting agencies But at some level, we all subsidize whoever has no means. This might be a better way of doing it, the ACA. In the ACA, the government defines what's adequate coverage. So the ACA was passed, but this is obviously the warning note from the vote in the House on March 21st, 2010, a very, very divisive vote. And that probably sealed a great deal of trouble that was to follow over the next 8 years, that you pass the legislation, no matter how much I like it, if there's no support, there will be a price to be paid. Coverage gains, this is based on National Health Interview Survey from the CDC. About 20 million more Americans were insured in 2015 versus 2020. I don't see indications that that has dropped very much. Medicaid had grown by 14.9 million since 2013, of which it was thought that 12 million had been made eligible by the Affordable Care Act, and other people just kind of crept out and joined in as they saw the opportunity to sign up. You'll see my figures are larger than the ones Tom showed. A lot of facts are disputed in this realm. The total insurance market has grown, the individual insurance market, so it's not dying. Now, a lot of these are not purchased on the exchanges. There's off-exchange purchases, so if you're not getting a subsidy, sometimes you get the best plan not on the sponsored exchanges, but off exchanges. As far as I can tell, employer-provided insurance did not shrink in any massive way, but I showed you a prior slide where for small employers, there's this long-term trend, which was not reversed by the Affordable Care Act. It was well in place before its passage, and it continued after its passage, which is that small employers find it hard to provide insurance, and only about 50% offer insurance to their employees. Medicaid expansion, what does that do? What does that accomplish? People use more health care, primary care, and emergency department services. If they get Medicaid, they do get more medicines for the kinds of diseases that you would like to see treated. There's less financial catastrophes. This is from randomized trial and observational data. What's the health impact? Clearly it matters a lot for some, but for a year or two of insurance, for one person it makes a world of difference, and for most of us, it probably leads us to go to the doctor more often, but doesn't necessarily radically change our health status. So there's, I think I put into the readings an article that argues that insurance improves health, but I think we're in agreement that insurance access is not the primary lever of improving your society's health. The costs are real, but as I'll explain, they're mostly covered by other aspects of the Affordable Care Act itself, and modest for more states, but still unaffordable if the state's tax base has not gone up to what it was in 2008 before the crash of the economy. And in many states that have chosen not to expand Medicaid, that is the reality. Their tax base is not back up to what it was in 2008, so they can't expand. So there's threats to the Affordable Care Act. 11.8 million enrolled or re-enrolled in the exchanges in 2018, which is 400,000 less than in 2017, so that's a signal of trouble. It partly reflects the shortening of the enrollment period. Yes, the Trump administration did that. If you watch Rachel Maddow, you see it as an act of sabotage. But the insurers requested the shortening of the enrollment period because it's very hard for insurers to plan the expenses of the year if all their enrollees sign up on January 31st. They need time to model out what are our losses and who are the people we're going to serve before they charge a premium. Premiums rose for many reasons we're going to get to. And Congress got rid of the mandate to purchase. The Center's Congressional Budget Office says premiums will go up an additional 10% on the exchanges and off the exchanges, essentially because of that removal of the mandate. And the number of uninsured people will also rise as a result of that act of Congress. You can see that there's been a bit of slippage in enrollment on the insurance marketplaces. Still high. This is, I think, 11.5 million. But it slipped a bit from maybe its high in 16 to 18. Polling is favorable for Democrats, terrible among Republicans, and slightly favored among independents. But historically, compared to 2010 to 17, the law is more favored today than it was for many of the first few years that it was in place. The insurers themselves are not doing badly in terms of selling this product. Of course, that's because they're raising the premiums. But the margin between how much they charge for a premium and how much they have to pay out in claims is the distance between the blue line and the orange line. And that margin has risen as insurers have priced upward based on the fact that Tom said that more older and more sicker people signed up than they had originally projected would sign up at the initiation of the law. But insurers are making money. The hits are these things we talked about, the cost-sharing reduction payments, where insurers are supposed to, they're mandated by law to reduce out-of-pocket expenses to people who are poor. They're still doing that. They got to recover the money somehow, and the federal government's not going to write them a check right now because of the dispute over whether Congress's intent in the law is sufficient to act as an appropriation for the rest of time, or whether Congress needs to appropriate that money like they do with other expenses. So for now, it's not appropriated. The Trump administration says we can't pay this without an appropriation. Risk corridors, which is sort of protective of the insurers, kind of redistributing among the insurers. There's a lawsuit, as I mentioned. Centers for Medicare and Medicaid Services says as long as there's a dispute about how these things are supposed to be done, we're not paying it. There was a big cut in outreach for signing up for the Affordable Care Act. There was elimination of the penalty for not purchasing insurance. And there's been, now proposed an expansion and enacted an expansion of low-cost, low-benefit options outside of the exchanges, so you can buy a policy that doesn't cover you for mental health addiction, has maybe a max, and will price itself based on your health conditions that may last for, real time, up to 3 years. So what does this mean? There's, let me make sure I read this right. Less government requirement to buy something of a specified. So what has been achieved by these last 3 years of efforts to roll back the law? There's less of a government requirement to buy something that has a specified quality, this defined by the government insurance product, at a price that might in fact be too high. This reflects efforts by the elected party to honor the pledges it made. It also incrementally destabilizes Affordable Care Act coverage mechanisms, forces premiums up, drives people out of the pool because now those prices are going up, but it's probably not sufficient to kill the law. This is a little wonky, but the states that lost those cost-sharing reduction premiums, a lot of them finagled a way to keep the insurers whole. Hidden behind it is something called silver loading and silver switcheroos, which essentially amounts to this. Once the state realized that they were not going to get those cost-sharing reduction payments, they knew that it could really, if insurers simply had a cost problem and spread it to all people who might purchase insurance, it would hurt all purchasers, including the people with no subsidies. So what they did, mostly, a lot of them, is force all silver plans to charge a big fat surtax to cover that cost for the insurers. If you do that, then any subsidized person because the subsidies are tied to silver plans, any subsidized person is just protected and whole. Any non-subsidized person was kind of harmed if they bought a silver plan, and okay if they switched to bronze or gold. Then there's an even more sophisticated version called the silver switcheroo, which I won't get into, but they finagled even more ways to try to protect people by taking advantage of the fact that as premiums go up, more money comes to subsidize people who don't have money. So there's a lot of premium rise and efforts to buckle around the problems caused by the cost-sharing reductions. The costs are reflected in the premiums. This is from Charles Gaba, who runs a website called ACA Signups. Year by year, he's been one of the most accurate predictors of premium increases because he tracks things very carefully. But in red, what you're seeing is the premium increase that's basically due to the various steps taken by the federal government to reduce the effectiveness of the Affordable Care Act. And in blue, Charles Gaba calculates what the sort of unavoidable inflation under the insurance regulation that people are older and sicker, and this is just for last year, from 2017 to 18. Prior to a number of steps taken by the current administration, insurers were saying, look, our costs require us to increase premiums by 10.8%, but if certain things are done by the government, we're going to have to increase them by 27%. That's an average across the country, and that's pretty much what happened. They had to increase by a lot more than they were projecting because the government, Congress, in delivering on a political promise, successfully took the steps necessary to increase premiums by a lot more than they would have increased otherwise. But the law's not dead, and to quote the great Elton John, "Don't you know I'm still standing better than I ever did, looking like a true survivor, feeling like a little kid. I'm still standing after all this time, picking up the pieces of my life without you on my mind. I'm still standing, yeah, yeah, yeah. I'm still standing, yeah, yeah, yeah." That is the Affordable Care Act. Okay. Suggestions to improve it. Let's unburden the 9 million insurance purchasers who are over 250% of poverty so they don't foot so much of the bill for the people who are sicker on the exchanges. I think this is totally fair. We should provide them with subsidies. We should provide them with help because people who are buying on the exchanges don't get the giant tax break that benefits all of us who are in the insurer-provided market. So why don't we somehow, I'd be willing actually to reduce my tax break in order to help those people, which is not a very large number, who are buying on the exchanges without a subsidy. Let's allow insurers to charge younger people 1/5 of older persons' premiums rather than 1/3, and allow subsidies for older people to rise if necessary to cover that. Let's increase and strengthen rather than end the mandate to purchase insurance. Let's boost the outreach, the navigation to buy insurance on the exchanges, and I don't know why I said this, get congressional approval for, yeah, I would like to see those cost sharing reduction monies allocated. But of course, we still have a national health expenditure problem. None of that's solved by anything I've said. Just to show you the dollar figures, total expenses of the nation on health care for 2018 versus 16, dauntingly high. I mean, you know, it's going to go from 3.7 trillion to 5.7 trillion. It's not the government. This is like all of us together are going to spend trillions of dollars. Medicare and Medicaid, trillions of dollars going to rise. What the states spend on Medicaid is going to rise, $383 billion proposed for 2026. Now, how much did they actually spend for that expansion of Medicaid, which Alabama can't afford, which is true? $8.5 billion. So when you talk about the cost impacts, realize our healthcare system's costly. The ACA itself is not the biggest driver. The fundamental thing that drives cost growth in our healthcare system are this combination of factors, and this is from the actuary of the Centers for Medicare and Medicaid Services, the mix of patients, the population, the ability of providers to charge as high a price as they want. And Tom and I are in agreement with that the providers jack their prices and direct you to get services that are costly because it's profitable. Everyone must have a proton beam, a radiotherapy pump, device at, whatever, $100 million or whatever they have to spend to buy it, even if it's not proven to be superior, because that's how we make money on the market. And use and intensity. Those things are the underlying factors. We spend too much. I'm not going to get, and the deficit is the deficit. I'm going to come across. So the ACA, the too long don't read version of this is the ACA per se had expense increases, which are in green, and expense reductions in terms of taxes and ways of reducing expenses that are in red. When the actual simple repeal of the ACA was voted on, the basic expectation was the deficit would have to go up because you'd be repealing all the various taxes and expense reductions that were built into the ACA to pay for the coverage expansions. So as a law, that law itself has proven not to be a deficit burner. And then tax cuts, obviously we've learned that, in political reality, the deficit, as much as we seem to be concerned about it in rhetoric, the deficit impact has not been something that's worried the Congress very much. $1.9 trillion in additional deficit cumulative were imposed on us as a result of the combination of the tax cuts and cost of interest passed at the end of last year. If we repeal the mandate, we will have fewer insured people, and that's what's projected by the Congressional Budget Office. At the systems level, I think Medicare should negotiate hard for things like medications, which are much more expensive here. I would invest in primary care every which way and make that job more attractive. Tom's point is fair that specialists often drive the expenditure patterns in our system, and I think we need to fight for primary care, which is often a lower cost service. Medicare should require competitive bidding for equipment, tort reform, antitrust action against mergers. I want to just get to the issue of conversation. So who is the man on the left? Shelby, yes, Senator Shelby. Now, of course, he's not a man of the left, he's a man of the right. But if you're from his perspective, I'm on the left and he's on the right. So we met at the airport in Washington a year ago, and I'm going to give you the verbatim conversation first, which was, hey, thanks for writing a letter back to my son. We're kind of liberals. And he said, well, I'm a conservative, but I'm not crazy. And that I remember verbatim. It was a nice conversation. Then he sat next to me on the plane all the way home. And so we talked about a variety of subjects. He's a very talkative man. So this is a paraphrase. I said, what do you think of this repeal of the Affordable Care Act currently before Congress. This is last year. He said, we got to deal with entitlements. It's a long-term budget issue. Okay. Do you think we should cover people's health care? Yes, but we can't just cover all the people who are able-bodied. Able-bodied people, he's uncomfortable with that. And then I said, if the concern is long-term deficits that we need to deal with, does it seem at all inconsistent to cut the Affordable Care Act expansion at the same time as passing a tax cut of exactly the same size legislatively? And he changed the conversation subject. And I felt, since I was sitting next to him on the plane, it would be rude to persist and hammer him like a journalist, and so I didn't. And we just kind of left that subject behind. So I'm going to just point out, only one of us has faced the Chinese in open combat. Fenced in Shanghai. Okay.
You got any more famous names to drop, Dr. Kertesz, that you've ridden on the plane with lately? Okay, let's convene the panel. If you all would come down here. Yeah, I'm going to stand. No, you guys take the seats. So you have met Dr. Durant, and you have met Dr. Kertesz. We also have Jay Locks, who is the nursing director for clinics.
All the primary care clinics
In the UAB health system. We have Dr. Ann Schmidt, who is senior medical director at Blue Cross Blue Shield of Alabama, and I'm so grateful that she's been able to join us. And we have Dr. Bill Curry, who... All right.
I didn't know you were so popular.
Now, I tend to get your title wrong. Are you a senior associate dean?
I'm just an associate.
Associate dean for primary care and rural health, senior VP for population health for the UAB health system. Okay. So a panel of people with varied backgrounds, varied outlooks, and I'm hoping that before we open it up to all of you, that you all will provide us some insights, some comments, some thoughts about really anything you want to say. It doesn't have to necessarily relate to what Dr. Kertesz and I talked about, but health policy, where we should go, where we are and where we should go. So please take it away. Any one of you.
Start on this end. Well, thank you, and I appreciate my cheering section very much. That's my small group. We joked about that yesterday, but we had a great time. I'm sure everybody else's small group did too, right? So you all had a wonderful time in that. This is a great course, great way to start medical school. So let me say that from the perspective of what we need to do to reorganize the way we deliver and the way we finance health care, there's no question there need to be changes in my mind. I suspect we all agree on that much, that the status quo is not satisfactory, at least for big sections of our country and our population. But we disagree wildly on how to do it. I think the important thing is that we try to find a way to stay civil and friendly with each other, and actually, you know, Dr. Kertesz and Dr. Huddle are a great model of that. You couldn't get a whole lot further apart on the solution, but they're good friends. And I think that's what we're lacking in Washington and to some degree in Montgomery too. So I think that's a great thing for you to get to see. I just want to make sure that gets said. I tend to be suspicious of big government solutions because they tend not to work out very well, just at a pragmatic level. I want everybody to have some kind of coverage. I work Tuesday afternoons with uninsured, high-risk diabetic patients who can't afford $26 at Walmart for their insulin. And so they wind up back in University Hospital over and over. So I want something that solves that problem. It's taking an investment by the UAB health system to do that, but the health system saves by doing it. So I want something on a bigger scale that helps with that. But it's very complicated. I'll just say this about the ACA. I think, and I can get in more depth. I don't know if you want us to go a long time now or just keep coming back and forth. What do you want?
More back and forth.
Okay. All right. Let me just say that someone once said that A camel is a horse designed by a committee, and the ACA is living proof of what that can look like. It was well intended, it was a great idea in some ways, but it's been very poorly executed, and I think we can go into detail about just how poorly executed and how much it needs to be redone. But I think we need, I want coverage for everybody. I agree with Dr. Huddle, but I also disagree with him on some points, so maybe we can get into those things.
All right, thank you. Again, I'm Ann Schmidt. I'm the Senior Medical Director at Blue Cross Blue Shield of Alabama. And I know that a lot of times, especially coming into medical school, we have this dichotomy between providers and payers. And I think to Dr. Curry's point, it's a conversation that we need to keep open. I know at Blue Cross we're very open to input, especially from our physicians, from our nurse practitioners, our PAs, who are working out there every day. So I just wanted to start with that we are always open to feedback from you guys. If it wasn't for y'all, we wouldn't be the payer of choice in this state. So just wanted to start with that. We also, in addition to policy, in addition to the fiduciary responsibility we have for our individuals and for our group population, I have to put in a little plug for health management. We offer resources for case management and disease management. So a few years from now when you're out there in practice, also think of us when you think about chronic disease and things like that. Because it's not just about paying, it's not just about the utilization management side and prior authorizations and whether we're going to cover this drug and on what tier. We really do want to partner in the health of our population in Alabama. We're here, we're based here. We're not a United or an Aetna, that's a national organization. So when you talk about having us on this panel, we really appreciate the chance to be out here. When you talk about policy in our state, obviously we're a big player. And with ACA premiums and everything, this is the first year that they haven't gone up substantially. We understand the impact that that has, especially for that unsubsidized population. So what can we do to really play in that space a little bit more? We're kind of working some with Medicaid in this state. We would love to be able to maybe provide a little more assistance on that side of things as well. So again, when you think about us, don't only think about the PAs and the utilization management and calling when you think you're going to get a denial for something, because we really are out there to partner in the health of the population of our state. Because without that, I mean, it's not good for anybody.
So good morning, you all. Good to see you again.
Was it that hard?
No. It's been a week since I lectured. That's why I said good to see you again. That's funny. As I think I mentioned during the patient interview lecture, I serve as medical director at Cooper Green, which is a local primary care and multi-specialty clinic here that provides care to a large number of uninsured residents of Jefferson County and some insured, but virtually all of our patients, regardless of insurance status, are low income. And in many respects, that has greatly shaped my perspective on healthcare and healthcare policy. We at Cooper Green serve as provider and payer. So we have a pot of money from earmarked tax revenue, and then we have a group of patients, and we've got to provide care for those patients with that pot of money, and that is sort of allocated on a yearly basis. So in many ways, I think I see things from both perspectives at times, and when I say both perspectives, I see it from the standpoint of sort of what payers, and I'm not suggesting that I'm an expert on insurance and coverages and that sort of thing, but I do get a sense for it. And then obviously as a provider and having to provide care for these folks. I think one thing that I do feel and believe and sort of shapes a good bit of my thought on the matter, and I think there probably some agreement on this panel. Certainly both Drs. Kertesz and Dr. Huddle touched on this, and that is the realization that in essence we're all in one sort of large risk pool. Obviously, we can sort of slice and dice by locale or by income or insured versus not insured, but we locally, certainly here in the metro area, have a citizenry, and if large portions of that citizenry don't have access to care, then that has an impact on the care that all of us receive, regardless of, you know, how well insured we are, how much access to care we have. There is a ripple effect, and I think that is a realization that I think would motivate us more to really sit down and think about, okay, how can we sort of make care available to everyone? Realizing that we cannot compartmentalize lack of access or in some ways even quarantine suffering with lack of access to one group or to those perhaps who are less fortunate. So I'll stop there and pass it on. And actually, before I pass on, I was remiss in passing on to Dr. Huddle Jay's preferred title, if Queen of Prime Care. I didn't get it to him in time. I can attest to the fact that it is a well-deserved title. She's Senior Director of Prime Care, and this really extends to sort of primary care throughout the